Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everyone, and welcome to episode number 63 of the Better Health Guy blogcast series. Today's guest is Dr. Garth Nicholson, and the topic of the show is mycoplasma. Dr. Garth L. Nicholson is the founder of the Institute for Molecular Medicine at California, and he serves as the president, chief scientific officer, and emeritus professor of molecular pathology. He is Conjoint Professor in the Faculty of Science and Technology, University of Newcastle, Australia. During the outbreak of the Gulf War syndrome, he was the leading authority on the study of the cause, treatment, and prevention of the disease. He was appointed chairman of the Medical Scientific Panel for the Persian Gulf War Veterans Conference. On suspicion of the bacterium that caused the disease as a product of biological warfare, he made extensive scientific investigations and served as authority to the United States House of Representatives. For his service, he was conferred honorary colonel of the U.S. Army Special Forces and honorary U.S. Navy SEAL. With S.J. Singer, Nicholson published a paper titled The Fluid Mosaic Model of the Structure of Cell Membranes in 1972, which is now regarded as a classic paper in cell biology. With over 600 scientific papers, the majority of Nicholson's research is in cancer biology and cellular properties related to aging. He has invented a number of techniques in the study of cancer and has 5 U.S. patents. He was a Nobel Prize nominee in Cell Microbiology. In 2003, he introduced the practice of lipid replacement therapy into a scientific concept. He observed that the therapy had anti-aging effects, restorative potential for chronic muscle weakness, and was beneficial to patients undergoing cancer treatments. Dr. Nicholson found that at the cellular and molecular levels, the actual replacement of damaged cellular lipids with undamaged lipids helped to maintain proper structure and function of cellular structures, mainly cell membrane and organelle membranes, especially those of the mitochondria, and this is important for maintaining stable cellular functions. And now, my interview with Dr. Garth Nicholson. I had the honor of writing an article in 2009 in the Public Health Alert with Dr. Nicholson on the topic of mycoplasma. And here, almost a decade later, this is really a full circle moment for me as we're going to talk today about mycoplasma with Dr. Nicholson. So thank you for being here, Dr. Nicholson.
It's a pleasure to be on your program again.
Thanks so much. So what is mycoplasma and how does it compare in size to either a bacteria or a virus? And then what makes it unique, and is it a stealth infection?
Well, it is bigger than a virus, but smaller than most bacteria. It's a rudimentary bacteria. It's lost genetic information and it's lost its cell wall. So it's a very primitive type of bacteria, and it has to live inside cells. So it's an intracellular bacteria. Most intracellular bacteria are considered stealth pathogens because they hide from the immune system by taking residence inside cells so it can be sequestered away from immune surveillance.
So what are some of the key symptoms and conditions that are associated with mycoplasma infections?
Well, this can vary widely among the different patients. And generally, patients they can have 20 to 40 different signs and symptoms. And without going through all of these in detail, obviously the ones that we're most concerned with are the ones that have to do with cognitive problems and memory decline and memory fog and things like this, gastrointestinal problems, obviously fatigue, and skeletal muscular problems and so on. So there are really very many signs and symptoms, almost too many to go through in a short period of time. And this can all happen because of this one infection, because it really gets disseminated throughout the body It ends up in all the various organs and all the tissues and ends up in our nerves, both our peripheral nerves and our central nerves. And in fact, it's a bit neurotropic, which means it tends to hide inside nerve cells, and this causes a lot of havoc with not only our central and peripheral nervous system, but also our immune system, which is tied into our nervous system. It also invades the endocrine glands, so it can cause havoc with the production of all the hormones and endocrine systems and so on. It can play a role in suppressing the immune system and plays havoc with the cytokine system, which is there to protect us and causes different problems with inflammation. And so there's just a wide variety of different problems that occur when you have these infections.
And would you say that conditions like Lyme disease, chronic fatigue, fibromyalgia, maybe even autism and Parkinson's, MS, Alzheimer's, even ALS, are these all conditions where mycoplasma potentially plays a role?
Yes, and we found them in all of those different diseases, in some cases in very high percentages. For example, in ALS or Lou Gehrig's disease or myotrophic lateral sclerosis, this occurs in 80 to 85% of civilians, and we found it in 100% of Gulf War veterans that came down with early onset ALS. So we think it's a principal component of the ALS problem.
And would you say that it is also a key contributor in some of those other conditions that we just mentioned, or is it just more of an opportunistic, common kind of contaminant that we see in these conditions?
Well, it can be either or both. And this is the problem that we face in dealing with mycoplasmal infections. It can either be the cause or cofactor in these infections. And so it's often difficult to tell, exactly whether it's the cause or whether it's just a cofactor.
Tell us a little bit about your Project Daylily book, and then do we believe that mycoplasma is a naturally occurring organism, or has it been tampered with in some way, and is that why it's a factor in many of these neurological conditions?
Well, it can be. Again, it's a very complicated situation because they're naturally occurring mycoplasmas. There are over 200 different species of mycoplasma, but there's only about 6 or 10 that are really known human pathogens. But these pathogens, the human pathogens, occur in a wide variety of different disease situations and different conditions and so on. And so it's often difficult to tell whether they're a cofactor or whether they're a cause or whether it's a comorbid condition in patients. We think it's more than just a comorbid condition, which means it's just a separate condition that involves mycoplasma, because it seems to be in such high frequency in many diseases, and it's found so commonly among those diseases. So we think it's a major contributor to the disease. Now, we don't know that it's a cause of the disease, but we feel it's a major contributor, particularly to signs and symptoms of the disease.
And so talk to us a little bit about the role of mycoplasma in Gulf War syndrome and the military personnel that came back and had these long-term illnesses. Was there a connection between Gulf War syndrome and mycoplasma?
Yes, there was. And we found that about half of the veterans that came back from the first Gulf War had this type of infection. And there were a variety of different causes of Gulf War. We call them Gulf War illnesses, plural. Because some of the troops were exposed to chemicals, some of them were exposed to environmental problems like the oil well fires, for example, and some had these infections. And we had such a high proportion with infections, about 45% in one of our studies, that we felt that this was a major contributor. And this was the contributor that spread the illness to family members, because you can't really spread chemical exposure to a family member. But we found many of the families were coming down with very similar illnesses to the veterans. And in that case, we found, in every case that we looked at, actually, that it was this infection that spread to immediate family members, and they came down with different diseases. Now, the children had problems with autism and autistic spectrum disorders and pediatric chronic fatigue and things like this. The adults were primarily chronic fatigue syndrome, and fibromyalgia syndrome. And if you look at the signs and symptoms of the Gulf War vets, it kind of fit a general pattern of chronic fatigue syndrome, fibromyalgia syndrome, depending upon the aspects of the disease and what other exposures that they had. So we were, again, finding this in families. We were finding it widespread, which meant that this was a very significant problem among the Gulf War veterans.
And do we know how the military personnel came into contact with mycoplasma?
Well, we can guess, and I think that it was through the vaccines. And there are a number of reasons for that. The first was that some of the troops that were ready to be deployed and were vaccinated, some of them came down with a very similar illness to the deployed troops. And then there were deployed troops who weren't vaccinated, mostly by accident, and they didn't seem to come down with any of the illnesses that we found in the general population of deployed veterans. And then there were embedded officers from other nations, like the French forces, for example, that were embedded with the American units. They didn't come down with these types of problems. So all of that adds up to really tracing it back to the vaccines.
So in the realm of Lyme disease, people talk about mycoplasma, and oftentimes they're referring to Mycoplasma pneumoniae. And I'm wondering if you can talk a little bit about the different types of mycoplasma that can be a factor in Lyme and similar neurological conditions. Are all of these human infecting mycoplasmas potentially problematic and symptom producing, or is one more significant than another?
Well, that's hard to say because they often occur as multiple infections, not only with other mycoplasma species, but also with other types of similar types of infections like chlamydia pneumoniae, for example, or other viral infections, or Borrelia, which is the organism that's associated primarily with Lyme disease. And all these really complicate the analysis of exactly what the mycoplasma actually does. And this is a real problem in chronic illnesses in general, because we find that most people that are chronically ill don't have a single infection. They mostly have multiple infections. Now, the one outlier to that were the Gulf War veterans. They had primarily the Mycoplasma fermentans. The other outlier is the children that end up with atypical pneumonia. Often the most common cause of atypical pneumonia is Mycoplasma pneumoniae. And they often come down with what looks like a single infection, but many of those also have multiple infections as well. So it's complicated.
So if we talk about co-infections versus opportunistic infections in Lyme, a co-infection is something that you acquired at the same time that you acquired the Borrelia spirochete infection. An opportunistic infection we think of more as something that maybe we already carried in our body, but once the immune system is dysregulated or suppressed, it can again become active. So from your perspective with mycoplasma, is it in those with Lyme particularly, is it more likely a co-infection, or is it an opportunistic infection that once again becomes a problem because of all these other infections that are suppressing the immune system?
Well, it's actually both. But we do think the mycoplasma is one of the co-infections. We find it in ticks. We've looked in Northern California, and other studies have looked in New Jersey and New York, and they do find the mycoplasma in the same ticks that carry the Borrelia. So we know that it's there in the ticks, and so that's one source. But mycoplasma is kind of unusual compared to other tick-borne infections. And I'm actually on the Health and Human Services National Tick-Borne Working Group in the subcommittee on other infections. And so I know this quite well, that Mycoplasma fermentans, for example, has been found in ticks. Mycoplasma pneumoniae has been found in ticks, not so much the other types of infections. If we look at Lyme, these are the two principal mycoplasma infections that go along with the Lyme disease. And quite frankly, since Lyme can also be an airborne infection, people could get it either way, either through an insect bite or through an airborne infection. So it's very hard to tell how somebody actually acquired a mycoplasma infection.
So I'm going to have to ask you more about that because I know people will ask if I don't. So were you suggesting that there's some information that suggests that Lyme itself can be transmitted through airborne means rather than just a tick bite, or were you talking about mycoplasma?
I was talking about mycoplasma.
Okay.
There's no evidence that many of the other Lyme-associated co-infections like Babesia and Bartonella can be transferred via an airborne infection process. These are mostly insect vector or insect-borne infections.
So in your research in those with Lyme, how common would you say Mycoplasma is relative to the other co-infections like Bartonella and Babesia or Ehrlichia and Anaplasma?
Well, we find it's the most common co-infection with Borrelia. Other people think it may not be the most common, but close to the most common. So it's obviously up there in terms of the percentage of Lyme patients that have Mycoplasma. We think it's about 60 to 70% or even higher.
I believe that I've heard you, and I know that I've heard Dr. Klinghardt talk about Mycoplasma even being something that can be acquired from air travel, for example, that we're constantly exposed to certain types of Mycoplasma in our environment. And so how easy is it to acquire Mycoplasma, and are certain types more present in the environment than others?
Well, Mycoplasma can be an airborne infection, and if you're infected and you're on a plane and you're breathing out, you will actually exhale little droplets, little fluid droplets, some of which could contain Mycoplasma, and people will breathing those in because the air is not really transferred. The air is recycled in airplanes. You're there for a long time, on a long trip, for example, so it's possible. In general, though, we think that the airborne transmittal of mycoplasmal infections is not very efficient compared to, let's say, insect vectors. So, yes, there's a possibility there. How, in a practical sense, that's a danger. We don't know. We don't know the risk of air flight, travel, and infection, but it's something, but we just don't know exactly what it is.
I've read some of Dr. Richie Shoemaker's work where they talk about looking at all of the different contaminants and toxins in water-damaged buildings. And I know on that list, they list Mycoplasma and they also list chlamydia. And so I'm wondering, have you come across any association with moldy buildings being a source of ongoing exposure to Mycoplasma?
Well, we haven't looked at that ourselves, so I really can't comment on mold buildings, except that mold itself does weaken an individual's immune system. And if they're carrying Mycoplasma, and some people commonly might carry it in their oral cavity, we don't think that's an infection, by the way. We think that's just a normal colonization of environmental bacteria. And it generally doesn't cause anybody illness. But if your immune system is suppressed, then it can cause problems because it then has the potential to spread and actually enter your system. So we don't consider it a real infection until we find it in the blood, for example, or the tissues. We don't consider it an infection if we just find it superficially in the sinus or the oral cavity.
So that was kind of my next question, which is, do healthy people also carry Mycoplasma? And is it something that potentially we all have? And it sounds like, yes, we may all have some Mycoplasma, but it may not actually be causing us a problem. So is that a reasonable way to look at it?
Well, that's a reasonable way to look at it, and it's also a numbers game. Yes, could we come in contact with and carry a small amount of, let's say, Mycoplasma in our oral cavity or our sinuses? Yes. But will it cause disease? Probably not, unless there's some breakdown of the blood barrier to infection. But once it gets in the blood, they can potentially spread to any other tissue, for example. And so we think that's the main problem, is when it becomes bloodborne, not so much that it's around, because it can be around.
Okay, very good. Let's talk a little bit about testing. So it seems that there still aren't great tests for many of these co-infections or opportunistic infections for Mycoplasma, particularly. I know over the years, the labs and so on have kind of changed. From your perspective, is it best to evaluate Mycoplasma with an antibody-based test or an antigen-based test? And is there a good way to test for Mycoplasma currently?
Well, currently, I'm afraid that there isn't a foolproof way to test for Mycoplasma. There are antibody tests, and these are somewhat limited. They're better for some than others. They're better, for example, for Mycoplasma pneumoniae than they are for Mycoplasma fermentans and some of the other species. So antibody tests can be used for some of the species, but in general, these little microorganisms hide inside cells away from the immune system, and unless they're released, they really don't stimulate the immune system. So one of the ways that we've gotten around this is by giving a brief shock treatment of antibiotic to release mycoplasma from cells. Then they're out in the blood system, and then we can take a blood sample and actually test for them. And there are ways to test the blood besides antibody tests. And of course, using molecular tests like polymerase chain reaction or PCR is one way to really very carefully pin down exactly what type of species are present in a biological sample. Again, the problem is the sampling. In that sample of blood, do we actually find the microorganism? Because it's generally inside the white blood cells. Do we get the white blood cells, enough of them to find it? Or is it just in a small amount in the blood, and so we miss it just by the sampling problem? So these are all problems which we're trying to overcome, and they'll require, I think, some new technology.
So is there a lab that currently does a PCR test for mycoplasma that you think is worth exploring?
Well, there are a few labs. One of the ones that we recommend is CloneGen in Germantown, Maryland. They do a pretty good job. They're now focusing on what they call a urine test because they think that they can find it and detect it better in urine, more reliably in urine. Again, I really can't comment on that because I haven't seen the validation studies that are necessary to show that or to prove that. And in the past, we've primarily worked with blood samples, but we know that these are problematic unless the microorganism is released into the blood at the time we do the test. So in general, what we've done is we've tried to shock the system with a several-day treatment of antibiotics up to 1 week, and then take a blood sample, and then we know that it's much easier to find it in the blood. So there are a number of different ways that this is done, and some of the newer procedures that are coming out, I think will improve this. We have a much higher level of confidence in the results than we've had in the past.
So you mentioned that mycoplasma is primarily found in white blood cells. So that's interesting. So the exact cells that are intended to protect us from these foreign invaders, it sounds like mycoplasma is infecting them. And is that part of then why mycoplasma can be a contributor to immune suppression?
Well, they're both true. I mean, in part, some of the white blood cells engulf the mycoplasma as part of the natural mechanism for removing bacteria. In other white blood cells, they're actually infecting the cells. So again, it depends on exactly what type of subcell in that white cell category you're talking about. There are a wide variety of different cell types in the category of white blood cells.
Okay. So it's both that the white blood cells have actually identified some of mycoplasma and are doing what they should do to defend us, but in other cases, mycoplasma may actually be infecting those cells and thus impacting our immune system.
Yes, exactly.
Okay, perfect. So is it important to explore the possibility of family pets, for example, as a reservoir for mycoplasma if you're trying to optimize the outcome of treating humans in that family setting? Are pets a potential exposure as well?
Well, pets are a problem in families that have a lot of pets. Pets have different degrees of sensitivities. For example, birds are incredibly sensitive to mycoplasma. And people that have birds find that if somebody in the family has a mycoplasma infection, that could kill all their birds. And, they're very sensitive to it. Cats and dogs would be, in terms of numbers, the highest amount, and they can get it from humans, for example, or from other pets. And when they get it, they can be treated just like humans. And in general, that's what we suggest. And what we see in the pets that get mycoplasma is things like hair loss, fatigue, malaise, all these problems. They have vomiting. They have, they go through different bouts just like humans. And so some of the same signs and symptoms you see in pets that we find in humans.
And if you don't do something to treat the pet, does that potentially serve as a source of re-exposure for the human as well?
Well, it could, but it's my belief that you never totally eradicate the mycoplasma when you're infected. I mean, just like many viruses that you are exposed to in childhood, and you may suppress the viruses, and then at a later age when you're older, because your immune system declines, all of a sudden those viruses become a problem again. You've held them your entire life in a reservoir in your system, but they haven't been a problem until your immune system declines. And so the same thing could happen with the mycoplasma. There's an added problem with the mycoplasma because it can actively itself suppress the immune system. So This doesn't mean that you're home free if you completely suppress a mycoplasma infection. You have to be diligent and work on your health essentially for the rest of your life.
Okay. Yeah, and that's consistent with what my understanding was as well. So let's talk then about treatment options. I know some doctors suggest that they don't use antibiotics for mycoplasma because it can be a very long course of treatment, that they can get re-exposed easily, that maybe they cannot fully eradicate it anyway. So what are your thoughts on treating mycoplasma with antibiotics versus other natural options?
Well, we use both.
Okay.
Because quite frankly, you have to use both. The antibiotics are very useful in suppressing the more acute phases of the infection. And without the antibiotics, it's very difficult to suppress the more acute phases of the infection. But once that phase is gone and you have a more lingering chronic health problem, then often some of the other procedures, some of the homeopathic approaches and some of the other procedures are very beneficial. So you really need both.
So I know there have been a number of herbal and homeopathic treatment options that have emerged for mycoplasma over the last several years. Are there any natural options that you have found helpful in those that are dealing with mycoplasma? Any herbs, homeopathics, colloidal silver? What stands out for you as potentially helpful in that realm?
Well, it's very patient dependent. And this is the problem. And we tell patients they need to try a number of different things and see what works for them, for their body, for their system. We can't really predict if someone should take, for example, product A and this will work for everybody, because it just doesn't work that way. Everybody's systems are very unique and different. And so you have to try a number of things and just see what works. So there are a number of different homeopathic or natural supplement approaches to suppressing these infections, and you just have to try them and see what works for your system.
I know one of the things that Stephen Buhner's talked about is using olive oil in mycoplasma. Have you come across that before, and have you seen that helpful in dealing with mycoplasma?
Well, olive oil is useful in a general sense for health. Yes, the lipids are important in mycoplasma. What I'm really most excited about is, and we'll talk about it a little bit later, is lipid replacement therapy, or membrane lipid replacement, as I call it, which is using the actual membrane lipids to help rebuild the damage that's done by mycoplasma and other infections as well. So this is useful for viral and bacterial infections in general, and fungal infections too. So this is something that is really a universal healthy treatment for an anti-aging as well. So this is something that we could get into a little bit later.
Yeah, absolutely. So let's talk a little bit about how we might pulse treatment towards the end of a protocol once someone is largely asymptomatic from a perspective of mycoplasma, in order to minimize mycoplasma kind of getting a foothold again, or kind of developing a recurrence. Is there a pulsing methodology that you find helpful in dealing with mycoplasma long-term?
Well, in general, one of the main procedures that we use is a pulse treatment. We also use a continuous treatment, but again, it depends on the individual. Some people, their systems work better with the pulsing, and others, they seem to do better with continuous treatment. But when you get to a certain point, and this can be 6 months to a year along in the treatment, where it doesn't make sense to continue to treat people without really seeing if they need the treatment. And so then we go to a pulse procedure. Generally, it's something like a 6-week on, 2-week off the strategy. And if within the 2 weeks they don't relapse, then you can consider to maybe going off the therapy for a while and seeing if they're okay. But if they do relapse, you put them back on therapy. In general, we haven't found the problem of resistance and acquiring resistance as problematic as most people might think. So somebody that's, for example, been treated with doxycycline, which is one of the frontline antibiotic procedures for the treatment that we propose for mycoplasma, it will eventually suppress the infection, but it does take some time. It can take 6 months or even a year in some patients. But then once you get off that treatment and you're just on more or less supplement supports and other things to maintain your health, if you get run down, or let's say you get in an automobile accident or under specific emotional or heavy emotional stress, and you relapse again, we found that you can often go back to that primary treatment and it's just as effective as it was before. So we don't find the problem of resistance to be as great as we thought it was when we first started this.
So once someone's done some period of time with pharmaceutical antibiotics for mycoplasma, they then maybe move into this pulsing strategy. Maybe they incorporate some natural options. Once they're kind of maintaining it with natural options like herbs, for example, then could you apply that same pulsing strategy to the natural therapies as well? Or is that primarily for the antibiotic options?
Well, it depends on what you're using for the natural therapy. Many of the natural therapies are really general support mechanisms. They work on the general support systems. They're not really antimicrobial. What they do is they build up your natural support so that you can keep the microbe suppressed. So those, I would continuously use those. And we put membrane lipid replacement in that category. For example, we put vitamins and minerals in that category. We put things like transfer factor in that category. So these are things that you would use just continuously. You wouldn't bother to pulse them.
Okay. And that was actually my next question, was the transfer factor piece. So I have seen people that have had some good results dealing with mycoplasma with transfer factors after a period of more specific treatment. Are you also finding that transfer factors potentially play a role in maintaining their progress from the mycoplasma treatment?
Yes, we find it's very good. Again, it depends on the individual patient. Some patients do better on transfer factor than other patients. But we find that's a very good product or series of products to put patients on, particularly after they've gone through their main antibiotic therapy.
And is there a specific transfer factor product that you like?
Well, there are several that we consider useful. I say useful because, again, it very much depends on the individual patient. And I can't a priori guarantee that any given product of transfer factor will work for every patient. It's just something that people have to try themselves to see if it works. And I know that's not very satisfactory, but that's just where we are. We just cannot determine whether a person's going to do well on these biologic approaches of microorganism control.
And are the transfer factors that you're talking about, are they more generic immune support, or are they the ones that are mycoplasma specific transfer factor?
Well, we've worked with both.
Okay.
But we do find that some of the mycoplasma-specific transfer factors are actually quite good at maintenance. The problem is they can't be used as frontline therapy because they're just not potent enough. That's when we have to use the antibiotics. But after we've gone through several courses of antibiotics and the infection is pretty well suppressed but still smoldering, then we can use the transfer factors in people's immune systems can come online and hold them in check.
Beautiful. How about oxidative therapies? Is there a place for ozone, hyperbaric oxygen, IV vitamin C? What is the effect of those on mycoplasma?
Well, they have a very positive effect, and these are present in our instructions as well, that people need to investigate these, particularly if they've not found a satisfactory result from just the antibiotics and supplements. They need to pursue other things. And we know that mycoplasma is a borderline anaerobe. It prefers very low oxygen. And so if you give it your system high oxygen, this tends to suppress it. And so hyperbaric oxygen, ozone therapy, things like this can suppress mycoplasmal infections, and they're very useful. Whether they're as useful for frontline treatment is not, it's not clear. But they can certainly be used for maintenance, and they can certainly be used for somebody that relapses.
Perfect. I had spoken with a doctor recently that said that his perspective was that mycoplasma was like the kid at the school dance holding the back door of the gymnasium open so that other kids can smuggle in their alcohol. And so what he's essentially saying is that he feels that we spend lots of time and energy kind of chasing the drunk kids, which is Lyme and co-infections and all these other things, when if we really focused first on the mycoplasma, we could kind of shut down the person that's holding the door open. And so I'm curious, how much of a role do you think mycoplasma plays in conditions like Lyme? And could it be that the linchpin that's required for all of these other microbes to stay around in the body is actually mycoplasma?
Well, we just don't know. I mean, that's the basic answer.
Okay.
We don't know the answer to that question. I think it's a very intriguing question. We do know that mycoplasma does suppress the immune system, and so this could be one of the reasons why other infections, when they have a mycoplasma co-infection, seem to go wild in patients and are uncontrollable. So that it is a factor, but some of these other infections like Borrelia can be potentially immune suppressing as well. So it's a very complex situation, and it may depend upon a number of different factors and also an individual's genetic and immune makeup as well. So we're not quite sure where we land in that, although we do feel that the mycoplasma, if left unchecked, will lead to other problems. And you've just mentioned that as allowing these infections to go nuts, and that's certainly a possibility.
Okay. I know you've mentioned in the past, and people ask, is mycoplasma potentially sexually transmitted? I know when we talked about this years ago, I think your response was something like, well, it's transmitted in ways that are much easier to come into contact with than sexual contact. And so there wasn't really a whole lot of discussion there. But what role does mycoplasma potentially play in the realm of fertility and pregnancy? And can it be transmitted congenitally?
Yes, it can. In all those situations, mycoplasmal infections are important, have been shown to be very important, particularly in fertility, for example, in pregnancy. Mycoplasmal infections in the third world, for example, are one of the most common reasons for miscarriage and spontaneous abortion and other problems associated with pregnancy. We know they're also associated very much with infertility, both in men and women. So yes, these are potentially major problems. And we find that particularly true in the third world.
And do we know if it can be transmitted during the pregnancy to the child?
Well, it's difficult to get a precise answer to that, but from my reading of the literature, because we haven't studied this ourselves, the answer is yes. It can be spread from the maternal source to the offspring during the pregnancy. For example, you find it in both pregnant women and their unborn offspring. When they sample the blood, the cord blood, for example, of the baby, you can see the babies right after birth being infected already as soon as they come out. So the answer is yes, it certainly can be. And again, a lot of these babies that get infected in situ in the mother, they end up being premature infants, or they end up being stillbirths, or other problems associated with pregnancy. So it's a major problem.
And it sounds like it's so easily transmitted between people that in a family unit, if someone has an issue with mycoplasma, the chances are pretty good that probably most people in that family unit have been exposed, right?
Well, most people have been exposed, but not everybody will actually come down with an overt mycoplasmal infection. And we know this from our study with the Gulf War families. This was a really good way to study this because the families we studied were healthy when the veteran came back from the war, and the veteran came back with Gulf War illness, and it slowly spread to family members. But in those families, not everyone became sick, not everyone became positive, but the ones that did were almost entirely the same species of mycoplasma as found in the veteran. And so we do know that it's transmitted in families. In the families that we looked at, it first was transferred to the spouse, and that's probably because of close contact, both saliva exchange and sexual contact, for example. Just being close to someone is put you at risk. And the children were at risk as well, but not as high as risk as the spouse. So eventually in a family, many of the members of the family would become sick, but not everyone. And so some members of the family were able to carry it on board, but not become an overt infection.
So as I was preparing for this show, I had asked listeners of the show to see if they had any questions. And one of the questions that came up was if Mycoplasma genitalium potentially plays a role in conditions like endometriosis, ovarian cysts, interstitial cystitis, and some of those female conditions. Does Mycoplasma play a role in those?
We think it does. And before I left the MD Anderson Cancer Center in Houston, I did actually a study of both ovarian cancer and breast cancer. But you mentioned the ovarian part. Let's just talk about ovarian cancer. And what I found was that I could predict the women who were going to die of ovarian cancer. They were the ones that were infected with mycoplasma. They had a very unusual course, unusually aggressive course of cancer. And we know from our other studies that mycoplasma can contribute to progression of cancer, both in vitro, in tissue culture, you can show it, and in vivo, you can show it in animal studies. So we think it does play a role, and it does play a role in cancer patients. And so it's not unusual that we find that it might play a role in turning benign to malignant lesions. In the case of endometriosis, that eventually becomes uterine cancer, for example. So we think it can play a role there. We know it plays a role in ovarian cancer, in the spread of cancer. Again, the patients that died of ovarian cancer were the ones that had widespread metastases, and we think the mycoplasma contributed to that, contributed to the progression of the cancer. Now, why do we think this is true? Well, if you actually study cells in vitro and you put mycoplasma in, the mycoplasma can interfere with the genetic information and cause changes in the genes and cause deletions and mutations and so on in the genes. So it can actually end up causing progression of cells, and you can actually see that in a very simple controlled situation. So I'm sure that this is occurring in vivo as well. When the mycoplasma gets in the cancer cells and it causes them to go absolutely nuts and become more progressive, more aggressive, and more metastatic.
Yeah, it's amazing how many different things mycoplasma can do in the body. I mean, it sounds like there's really not anything that it can't potentially affect, right? I mean, it's pretty much throughout the entire body, essentially.
Well, it is a systemic infection. And again, in different people, it shows up differently because of the organs that are infected. And for example, in some people, they might have a neurodegenerative disease, and the mycoplasma will not necessarily start that, although it could, but it will promote it. And again, it's a matter of progression. So we find that in the ALS patients, the ones that had mycoplasma, and many of them did, were much more, they progressed much more rapidly than the ones that were negative for mycoplasma. And we find this over and over again with various human diseases, that if the mycoplasma is there, it's an important cofactor in the disease process, and it can make the disease worse, it can make it progress, and it can cause additional problems on its own.
In those people that are dealing with ALS or ALS-like conditions, are there specific therapeutic interventions that you've come across in your work that seem to help people dealing with ALS?
Well, we've only done one really study because we've never had the money to do this. And that study only lasted for 6 or 8 weeks for most patients, and that's not nearly long enough. It would have had to go on for a year, I think, to be beneficial. We found that the patients which were at the early onset of the disease responded the best, and that's to be expected because in the process of progression of the disease, the cell death is actually involved, and once the cells start dying, you can't, no matter what you do, you can't recover those cells, they're dead. But in the early part of the process, where the cells are not, cell death is not so widespread, we could reverse this process by treating the mycoplasmal infection. At the later stages of the disease, the only thing that we could do is really shorten or slow down the progression. And that's about the best we could do with the highly progressed ALS patients. But the early process of ALS, yes. And in fact, some of the patients that we had in East Texas who became infected with the Mycoplasma fermentans, a very aggressive strain of it, and showed that they were either diagnosed with ALS or atypical ALS, where they didn't have a complete diagnosis, something was missing. Early intervention in those patients really allowed them to completely recover. Wow. And so that's something that has never really been seen in ALS. So most urologists would try and say that, well, those weren't really ALS patients, but they were the ones, the neurologists in the first place, to diagnose them with ALS. So I have to believe that they knew what they were doing when they diagnosed them in the first place, but
right.
I don't want to believe it.
So does mycoplasma play a role in autoimmunity, and is it a key trigger of inflammation in those people dealing with chronic infection illnesses?
Well, we do believe that it's involved in autoimmune disease, and it can do a number of different things to affect autoimmunity. One of the things that mycoplasmas do is they have what's known as antigen mimicry. They can make antigens that mimic normal host antigens. And if the host can respond against the mycoplasma, they'll respond against those mimicry antigens. But unfortunately, the cross-reactivity of that means that they will also respond against the normal antigen that the mycoplasma mimicry antigen was supposed to mimic. Now, the reason they use these mimicry antigens is really to hide from the host immune system. But when they're recognized, it backfires, and then all of a sudden you can have an autoimmune response. The other way this happens is when mycoplasmas leave cells because they're intracellular, they almost inevitably take a piece of the plasma membrane or the surface of the cell that they're inside with them. And so if the immune system can then recognize them, they may also recognize the piece of normal antigens present on the surface of the mycoplasma. And then we have what we call a concomitant immune response. The immune system responds against the mycoplasma and also responds against the normal host antigens carried by the mycoplasma. So that could result in an autoimmune type response as well. So there are different ways that this can happen. It does happen. In some patients, it's worse than others.
It seems that so many people dealing with chronic health challenges today also have gut-related issues, have leaky gut, for example. Does mycoplasma affect the gastrointestinal system, and is it a potential contributor to leaky gut?
It is, and leaky gut is a problem because whenever the gut is leaky, the pathogens that are in the gut then can gain entry into our systems, and this causes tremendous other problems as well. So a person, if they have this higher load of pathogens in general in their system because of leaky gut, they're going to have all kinds of problems with their illness. So it does certainly contribute to the severity of their illness and also the different types of signs and symptoms that are seen with their illness. So we do think that's important.
So let's talk now about lipids. I know that's the thing that you're right now the most excited about. So thank you for entertaining me with all of the mycoplasma questions. But I know you've been working on lipid therapies, lipid replacement therapies for repairing cell membranes and kind of regenerating, repairing, and restoring the body. And so did that interest come out of your work in dealing first with mycoplasma and the fact that mycoplasma damaged cell membranes, or was this completely an unrelated interest?
Well, it actually, cell membranes was really one of the basic things that I worked on when I first started in science. And the fluid mosaic membrane model was really the outgrowth of that. And this is the standard model for membranes in the textbook. Any biology or medical school textbook has the fluid mosaic membrane model as the basic model of membrane structures. So that's my background. So we know that lipids are important in membranes, and they provide the matrix of the membrane. And when lipids are damaged, a number of different things happen. And in the case of lipid damage, often it's oxidative free radical damage that damages the lipids, and then they don't fit together in the membrane quite right, or they don't interact with proteins correctly, or it causes other problems as well. But this can result sometimes in leakiness across the membrane or loss of function in the membrane or so on. Now, we've done a lot of work on mitochondrial membranes. Mitochondria are the little batteries inside our cells that provide over 90% of our energy needs. And so these are incredibly important. And the mitochondria, if they're not functioning properly, your cells don't have enough energy. And if the cells don't have enough energy, they can't make all the molecules that they need, and all the functions that they are supposed to provide then start to decline and go on the wane. And so it's a major problem. And so a lot of the work that we've done, for example, on fatigue and on other aspects of energy function involve mitochondria. And so the mitochondria are very sensitive to loss of membrane integrity. And it's the mitochondria are kind of a double membrane organelle. And it's the intermembrane system that's the most important, because that's where the high energy molecules are made, and that's where oxidative phosphorylation occurs. That's where the oxygen is used to help drive the high energy production system. So we know that that's where the energy is produced. And when things like mycoplasma or other chemical exposures, for example, or even radiation, damage the membrane of the inner membrane of the mitochondria, then there's less function. Function declines. There's less production of high energy molecules like ATP. And so the cells suffer because of that. So what can we do about that? Well, one of the things that we thought about doing early on was to replace those damaged lipids, because the lipids seem to be extremely important in that damaging process. And we have a natural system, it turns out, to replace those lipids because they get damaged anyway. Maybe not to the extent that we see during infections and during chemical and radiation damage, but nonetheless, they do get damaged and they have to be replaced. And as we age, this happens naturally. So during the aging process, we can lose up to 1/2 our mitochondrial function as you get to be about 90 years old. And so people who are 90, they've lost a lot of their pep and go, and they're limited in terms of their mobility and all these different things that happen partly because of loss of the high energy production systems in all their cells. And so this is something that we've gone after. We've used the natural system of replacement that's present in our bodies, but we've kind of charged this up by giving huge excess amounts of the important glycerophospholipids that are present in the inner mitochondrial membrane. And this is what I call membrane lipid replacement. So we're not just giving regular old lipids. We're not just giving a bunch of fats. We're giving very specific lipid molecules that make up the inner membrane of the mitochondria. And we're giving multiples of these because they're different types in the inner membrane, and we have to replace a lot of the ones that are damaged, not just a certain type. So we use mixtures of these glycerophospholipids. And the one mixture that I've done a lot of work with is called NT-factor lipids. And the NT-factor lipids are just a mixture of these glycerophospholipids. And you take them in high quantity orally, just take them in as powder or as wafers or in other supplements. And they enter your system as little tiny lipid droplets. We have a system that we've evolved with to take in massive amounts of these important lipids because we know our bodies know they're so important. They want to grab every one they can when they're in the gastrointestinal system. So we've evolved with this procedure of mass action that we can move these bulk lipids in this way and move them into our body so that we can actually ingest high amounts of these all at once, and they will actually get in our system. Most all of them will actually enter our system. So they don't enter as one by one molecules, they enter as these tiny lipid droplets in our systems. And these are shunted around through various mechanisms in our blood, for example, and delivered to various tissues. And then they get inside cells, and then they can replace the damaged lipids in the membranes of the mitochondria, for example, and other organelles as well in the cell, and restore function. And this is exactly what we see. We see restoration of mitochondrial function in people that have lost mitochondrial function, either through aging, disease, or other conditions, chemical exposure, for example, radiation. And once they've been replaced and the function is recovered, then a lot of the symptoms that the people had are then less severe. And some of the symptoms, for example, like fatigue or someone, there's really dramatic benefit to individuals that take these kinds of products. So I'm really excited about the use of this. We've also used it more recently to remove chemicals from individuals who have been chemically damaged. And this is a new exciting area that I'm really very excited about. We're working, for example, with the Airline Pilots Association of Canada and other organizations where people get exposed to chemicals and fumes, and they end up getting chronically ill because of that. And we find that we can slowly remove these chemicals. And there's a benefit to doing this slowly. And we didn't really realize this when we started, but this slow removal process means that people aren't terribly sick during the process of chemical removal. So this is something you want to do slowly, because the chemicals, when they're exposed, they can cause a lot of damage and a lot of the symptoms. And so by doing this slowly, we actually find that people slowly get better. And so this is something that we're really promoting as a way to improve people's health.
So I think many people in the Lyme community know you primarily for your work in mycoplasma, but actually your fluid mosaic model paper, I think that was 1972 that you really were looking at this work. And so the mycoplasma was actually kind of the detour, I think, from your work in this realm of the cell, right? That's really what your focus has been for many, many years.
Well, it was a detour. It's something that we had to get into.
Yeah.
There's a personal reason for that. I mean, my stepdaughter served in the Gulf War and came back, and she became ill. A number of other colleagues and so on became ill. So we started working with the Special Forces, with the airborne units, with the Navy SEALs and so on to help with their problems with the Marines. So this is how we got involved in it. And I'm not sorry that we did. There was a political price to pay for that, but that's all water under the bridge.
So when we talk about lipid replacement, you mentioned chemical detoxification can be supported. Do we know if mycotoxins from exposure to water-damaged buildings, if those are also detoxified through the use of lipids?
We think there are, but we haven't really proven that yet. But one of the reasons I think they are is that most of these toxins are very hydrophobic, which means that they're lipid-loving molecules. They're not water-loving molecules. Not all of them, but many of them are hydrophobic molecules. So they can be removed by the lipid replacement therapy. It's a slow process, but we think that this could be one of the adjuvant therapies that people employ if they've been in mold-exposed buildings, for example.
You mentioned that the body has mechanisms to do this repair separate from the lipid replacement. Are there things we can do to also support the body's ability to inherently repair these, or are we better off going down the path of introducing these exogenous lipid replacement options?
Well, we introduced the exogenous lipid replacement because this is the rapid way to do it. And by employing high concentrations of these lipids, we can drive it into the cells. This is what we found. The normal repair processes, in many cases, can't keep up with the damage because the damage is ongoing. And this is where you get a natural decline in, for example, mitochondrial function because the damage outpaces the repair. So this is a problem that we have to overcome. The natural, the repair mechanisms, they're just inadequate in the disease process or in aging in general.
What are some of the things that people notice when they start incorporating these lipids in terms of improvements of specific symptoms?
Well, fatigue is the most dramatic thing that they've found. We're doing a study right now on fibromyalgia. We find that pain is one of the things that people see a decrease in widespread systemic pain. We think this is occurring because the lipids are actually repairing the damage to the nerve membranes that transmit the pain signals. And I think it's actually stabilizing the resting potential of the nerves. We have to prove that. It's a hypothesis that I'm going to pursue with some neurophysiologists to see if we can actually find evidence for that. But it's something I'm pretty positive about that happens with nerve cells when we give them a membrane lipid replacement. But there are a wide variety of different signs and symptoms in these patients. Gastrointestinal problems, for example, those seem to be better with membrane lipid replacement. We think that we're doing better with problems with leaky gut with membrane lipid replacement because the membranes are very important in forming that barrier. And if those membranes become leaky or the lipids damaged, the barrier tends to break down. So membrane lipid replacement is important there. Not only in energy, but the immune system, it's incredibly important. So we think it may help in surveillance systems and so on. A lot of this has to be proven, but it's just anecdotal evidence suggests that this helps not only just the mitochondria, but it helps a lot of different membrane systems and cells, and that's important.
So people will ask if you're talking about phosphatidylcholine, and my understanding is what you're talking about is a much more complex blend of several different phospholipids, correct?
That's correct. Phosphatidylcholine is the major glycerophospholipid that's found in various products and so on. What we've done is we've made a balanced product that balances the relative amounts based on the mitochondrial inner membrane. So we put in things that are normally not present in those products. For example, phosphatidylglycerol, which is not present in most phospholipid products. This is a very important precursor for a very important lipid molecule in mitochondria called cardiolipin. And when cardiolipin is damaged, and this is one of the most sensitive lipid molecules in the inner mitochondrial membrane, there's loss of function. There's a direct correlation between loss of or cardiolipid damage and loss of mitochondrial function. So we know we have to repair that. you can't add cardiolipin as a supplement because it's not transported. It's not picked up and moved throughout our systems. It has to be made inside the mitochondria. So what we've done is we've supplied the precursors to that. And this is phosphatidylglycerol is a precursor to cardiolipin. And then we can replace the cardiolipin by providing the precursor and then repair the membrane damage and so on. So this is just one of the ways that the membrane lipid replacement works. It supplies the precursors as well as the actual molecules that are used in repairing the damage to the membranes.
So the products that are available, there's a specific ratio of the different lipids. That's something that you've been involved in helping to kind of put together. Are there specific products that are available that fit that ratio and the different components that you're talking about? What would those be?
Well, the main product that we've worked with is called Factor Lipids. And Factor Lipids now is in a wide variety of different products. It's in vitamins and mineral supplements. It's a standalone supplement itself. It's in various things. For example, it's in weight loss supplements because it just helps people lose weight because their mitochondrial function is important in losing weight. It's now put in products that help people with asthma, for example. And all kinds of different products now contain the anti-factor lipids. So this is something that we think is going to be useful for a wide variety of different supplements.
So if it has the anti-factor lipids, something like the allergy research or nutricology product, the anti-factor energy lipids, that would be the same substance that you're talking about here, essentially.
Yes, it's really all made by one company, Nutritional Therapeutics in New York, from New York. And all these different companies, Allergy Research Group, Nutricology, iHerb, all these different companies use that product from NTI.
Is there an optimal amount of this NT lipid that people should consume on a daily basis? And then is there kind of a maximum amount where we either don't get any more benefit or there's some potential downside?
Well, we haven't found a potential downside yet. And so there's no toxicity from these products. That's the good news. You can just take as much as you want, and there's no risk for having an adverse reaction to it or a toxicity. We found that for most patients, they need to take at least 4 grams per day if somebody's a patient with a severe chronic illness. If they use it as an anti-aging supplement, they need at least 2 grams per day. So that's generally what we've been recommending. That's our latest recommendations.
So going above 4, not really necessary to kind of get into that optimal range of being able to help repair and regenerate.
Well, we don't know because everybody's different. And so some people may actually require more than 4 because their transport systems may be different and so on. What we find with the chemically exposed individuals is they do require more than 4. And so we recommend that they actually double up on those doses. They could take 4 to 6 grams. That's what we're recommending for long-term slow chemical removal.
Any impact on heavy metals in terms of detoxification with these lipid replacement therapies?
Well, the impact is that most heavy metal removal requires mitochondrial function. And so supporting the mitochondria do help remove the metals because there are various enzymes and so on that are required in that process. And they need to be made, and to make them requires energy. They need to be supported with energy. So that's important. So that's one thing that we feel is important. Mitochondrial function is essential. So we're thinking about ways of combining this with chelators, which will actually chelate the metals and help remove them. So this whole transport process is important because as we remove the damaged lipids, for example, the metals come out in the same type of mechanism. They're sequestered, they're chelated, and then they have to be removed. And so this actually helps in that removal process because it's just kind of like a beltway that's going. And you put things on the conveyor belt and they move. And you put a lot of lipids on there and they help move it. So that's basically what we're finding.
You mentioned that mitochondrial function declines significantly as we age. Can we essentially stop that decline with this type of lipid replacement, or how much can we affect that decline?
Well, we've seen people 90 years old or plus regain mitochondrial function of the level of a 30-year-old after 8 weeks or so of membrane lipid replacement. So we think that they can recover some of their function, if not all of their function, potentially all of it. So we feel that this is extremely important in the aging process, in trying to lessen the aging effects and so on. So we do recommend it as an anti-aging supplement. I take this myself. I mean, I'm 70, going on 75 now, so I need to worry about aging, and so I take it daily.
I mean, that was actually going to be my next question is this part of the reason that your brain is still working so well? And I'm guessing you're going to say yes.
Well, we don't know, but, it certainly doesn't hurt.
Yeah, absolutely. So it's interesting too, because I know in the realm of Lyme disease, many people take long-term antibiotics. We know that antibiotics do have, in some cases, a negative effect on the mitochondria. And so it seems like this could also be very helpful in terms of just dealing with some of the potential downsides of treatment of Lyme with antibiotics in terms of helping to restore and regenerate the function of the mitochondria.
Well, that's certainly true. And we know that for every therapy that we give, there's often a downside of it. There's often a secondary effect, and in most cases, we try and lessen that secondary effect, but it can be a problem. This helps repair some of the damage that's done, and so it's very good as an adjuvant to most any type of therapy, whether it's frontline antibiotic heavy-duty therapy or whether it's radiation or chemotherapy for cancer, which we've shown that this is a huge benefit in helping people after their therapy, preventing the normal damage that occurs because of that therapy and helping the host recover from the therapy. It's a good anti-aging, and it helps in terms of allowing other supplements to act better because it improves the transport systems, for example. So it improves the ability for people to take in other supplements. It improves the supplement activities by providing energy that many of these require for their full function. So we think that in general, this is a very important tool.
I know that some phosphatidylcholines are soy-derived, and people have then concerns that they're reactive to soy and so on. So are these lipids soy-derived? And if so, my understanding is there's generally not any soy protein left. So the question is, if someone has a soy sensitivity, could they still use these lipids?
Yes, they can, because there are no soy antigens or soy proteins in the products. And that's important because these molecules that we use for membrane lipid replacement are the same as the molecules in our cells. So we're not really giving anything foreign, so it doesn't elicit a foreign reaction or an allergic or immune reactivity. There's just none present. So they're very safe, incredibly safe. There's no known toxicity to these. So you can take tank car quantities of these and there's no reported side effects. So people have taken 50 grams per day of these types of lipids with no evidence of toxicity. So these are very safe. They're very useful. And I highly recommend it.
Is there any reason that they can't be mixed in a regular smoothie in the morning? Should they be taken separately, or is it okay to mix them in a smoothie?
You can mix it in anything. You can put it in baked goods. You can put it in a variety of different liquids, fluids, goods of any sort. They're really quite useful in that regard. Although some people just take it because if they get the powder, this is a colorless, odorless, tasteless powder. You could just put it in anything. It won't change the characteristics, except it makes it a little smoothier, creamier. So it actually improves the taste of most anything by making it creamier and smoothier.
Beautiful. Well, this has been super fun. I want to thank you so much for taking time out of your schedule. I know you are very busy, and I appreciate you taking time today to talk with us about the first part of the lecture, the mycoplasma, and then the second piece, which we got into even more detail than I was expecting. And I enjoyed learning more about the lipid replacement therapy as well. So I appreciate it. It was fun writing an article with you now almost a decade ago, and it was fun talking with you again today. So thank you. I know you are very connected with the patient communities as well, and really do a lot to help improve people's lives. So thank you so much, Dr. Nicholson.
Well, it's a pleasure being on your show again.
To learn more about today's guests, visit the Institute for Molecular Medicine at immed.org. That's immed.org. Thanks for your interest in today's show. If you'd like to follow me on Facebook or Twitter, you can find me there as Better Health Guy. To support the show, please visit betterhealthguy.com/donate. If you'd like to be added to my newsletter, visit betterhealthguy.com/newsletters. And this and other shows can be found on YouTube, iTunes, Google Play, Stitcher, and Spotify.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.